Welcome to the Deep Dive, where we take a monumental stack of professional documents, training guides, and yes, even a few candid forum discussions, and execute the most efficient knowledge transfer possible.
That's right.
Our sources today are focused entirely on the high-stakes world of commercial driver medical certification.
hmm We are deep diving into what it takes to become a certified medical examiner, or ME, the person who sits between a commercial driver and their license.
Specifically, we're dissecting the National Registry of Certified Medical Examiners, the NRCME exam, and the tough standards set by the Federal Motor Carrier Safety Administration, the FMCSA.
And our mission for you, the learner, is to grasp not just the clinical guidelines, but the unique, almost immediate mental shift required of any medical provider taking on this role.
That's a great way to put it, a mental shift.
Exactly. You are moving from a treating clinician whose primary job is the patient's health to a fitness for duty evaluator. Your focus shifts entirely to public safety compliance.
So the driver's health is still obviously important, but it's secondary to the regulatory threshold.
The regulatory threshold is paramount.
And this threshold guards the gateway for commercial driver licenses across the whole country. I mean, we are talking about the gatekeepers for every single person who moves goods and services across the nation.
Understanding these rules is a matter of national safety and commerce. It's huge.
Okay, let's unpack this with the fundamentals of the NRCME exam itself. Who exactly is certified to sit in that gatekeeper chair?
Well, the list of eligible professionals is incredibly diverse.
Yeah, it's not just doctors.
No, not at all. It's a huge umbrella, which is why everyone has to adopt that standardized FMCSA mindset. You've got MDs and DOs, of course medical doctors and doctors of osteopathy, but it also extends to doctors of chiropractic, or DCs.
And nurses and PAs.
Right, advanced practice nurses, APNs and APRNs, nurse practitioners, NPs and physician assistants, PAs, a really wide group.
So once this diverse group completes their required accredited training, they've got, what, 2 administrative hurdles before they can even sit for the exam?
Yes, they need to get that certificate of completion from the training, and then they have to apply to the DOT FMCSA to get verified and assign their unique 10-digit national registry number.
And only then can they schedule the test.
Only then. And passing this test grants certification for 10 years.
Though recertification is a looming commitment we'll get into soon, but getting there means tackling the test itself. The logistics are pretty interesting. It's closed book, in person, and administered by centers like Prometric or PSI. It's 2 hours long.
And here's where the test format itself presents a nasty psychological quirk.
Okay.
It's 120 questions in total, but only 100 of those are actually scored.
That is the critical nugget, isn't it? You've got 20 pilot questions mixed in that are being tested for future versions, and you have no way of knowing which questions count and which ones don't.
None at all. You have to answer every single one, and you're aiming for a 71% passing score on the ones that do count.
Wow.
It creates a unique pressure. You have 2 hours for 120 questions, which means you have roughly 1 minute per question.
You can't afford to get bogged down.
Not at all. The recommended strategy is to move quickly, use the computerized system to eliminate poor choices, and flag those few really tough questions to come back to only if you have time left.
But the strategy isn't just about speed, is it? It's about perspective. Our sources consistently emphasize that when you're answering, you must adopt the medical examiner's lens.
Yes. The questions are designed to test your adherence to the regulation, not your general clinical knowledge. I mean, we've seen anecdotal cases where MEs certified based on clinical judgment.
What they knew was safest for the patient.
Exactly.
Mm.
Only to be audited later because they didn't follow the specific letter of the FMCSA regulation. The correct answer is always the one that prioritizes driver fitness for duty based on the DOT rulebook.
That distinction is just, it's key. Okay, so we've established the enormous mental shift required to pass the test. But certification isn't a set it and forget it kind of thing.
Not even close.
Huh?
Once you pass, you immediately run into the long-term administrative commitment. Maintenance is a structured commitment.
Right.
The FMCSA mandates periodic training every 5 years, and then you have to complete refresher training and pass the full recertification test every 10 years.
Which means you need to stay current. And providers need to be aware of the updated guidance immediately. The major takeaway from our sources is the new Medical Examiner's Handbook 2024 edition.
That became effective on January 23, 2024.
And that handbook replaced all previous editions. Why is that so crucial?
Because it includes key updates, specifically to the medical advisory criteria. If you're studying old materials, You are basically setting yourself up for failure.
But how long does it take for a massive rulebook update like that to fully filter into the testing centers? I mean, are we confident that what's in the test bank reflects 2024 guidance, or is there a notorious regulatory lag?
That lag is precisely what creates the friction we will discuss later. But administratively, there's an immediate real-world scheduling issue you need to know about right now.
The backlog.
Yes, the backlog. See, back in 2014, when the registry was new, over 17,000 providers became certified in that first wave.
17,000.
Yeah, compared to an average of only a couple thousand a year after that.
Yeah.
Now, that massive 2014 cohort is hitting their mandatory 10-year recertification deadline all at once.
And the administrative system is just strained.
It's completely swamped. So if you're a provider trying to schedule your recertification exam right now, you might run into significant delays. It feels like hitting a brick wall.
So what's the solution? You can't just wait.
No, the solution isn't passive waiting. Our sources gave us the specific administrative hacks for dealing with this bureaucracy.
Yeah.
You have to be proactive. First, call the FMCSA directly at 617-494-3003.
And there's a trick to it, right? A
Yeah.
sequence of prompts.
Yes, you press option 2, then number 6, to bypass the long introductory greetings and get straight to a human who can actually help with verification.
Okay, what else?
Additionally, compose an email to fmctechsup@.gov requesting verification. And the most common piece of advice is to try scheduling the exam at the end of every business day,
Okay, then.
because the online system only releases slots after daily administrative updates, often confirming verification late in the afternoon.
Wait, so the solution to a massive government backlog is basically persistence meets bureaucracy. You have to make specific phone calls and hit refresh at the end of the day.
It sounds like the most frustrating game of administrative chicken imaginable, but yes,
Wow.
it is. But that commitment is necessary to maintain the privilege of performing this safety-critical exam. Now let's get into the clinical substance, which often forms the bedrock of these difficult test questions.
Okay, let's do it. We're heading straight for the cardiovascular system.
And this is where the ME role becomes intensely specific. It demands memorization of high-stakes numerical thresholds.
That's right.
Exactly. The foundation for all cardiovascular recommendations stems from the Framingham Risk Score, specifically predicting a 20% coronary heart disease event risk over the next 10 years.
That's the line the FMCSA uses to guide its decision-making.
And for drivers presenting with multiple medical issues, there's one simple overarching rule you have to know.
Okay.
If a driver has multiple cardiac or comorbid conditions, the longest waiting period must pass prior to certification.
So you always default to the most conservative, safety-first time frame.
Always. Now, the key numbers here are non-negotiable. For certification, left ventricular ejection fraction, or LVEF, must be greater than or equal to 40%.
And if it's lower, the driver is just not fit for duty.
That's it. Furthermore, pulmonary hypertension, which is defined as pulmonary artery pressure greater than 50% of systemic SBP, is an automatic disqualifier.
Let's pause on that LVEF number. For listeners, what's the practical significance of that 40% cutoff? Is that the line in the sand that separates certification from disqualification every single time?
It is the hard line. LVEF indicates how much blood the left ventricle is pumping out with each contraction. Below 40%, the risk of sudden incapacitation while driving a commercial motor vehicle, which could weigh 80,000 pounds, is just deemed too high.
It's a pure public safety mandate.
Purely.
Okay, let's run through the specific waiting periods, because understanding the contrast between different interventions is, I imagine, key to passing the exam.
It absolutely is. Take a myocardial infarction, a heart attack. The minimum waiting period is 2 months.
2 months.
Max certification is 1 year. And certification requires that LVEF of 40% or more and a satisfactory exercise tolerance test. That 2-month window reflects the acute risk period post-injury.
Now, contrast that with an intervention like a PCI or stenting. The waiting period there drops dramatically.
To just 1 week.
Yeah.
That short period reflects the immediate success rate of modern stenting procedures.
But the follow-up still matters.
Of course. An ETT is still required, typically 3 to 6 months after the procedure, and the certification period remains short, 1 year maximum, to ensure they're being monitored.
And for the most invasive common cardiac intervention, a CIBG, bypass the waiting period, snaps back up.
To 3 months minimum. This is primarily because the sternum has to be demonstrably healed before the driver can safely perform the activities required of the job.
Right. And post-CIBG, the LVEF of 40% or more rule Still applies.
Still applies. Recertification is annual, and once 5 years have passed post-CABG, the driver needs an annual ETT to demonstrate continued stability.
We also need to remember non-coronary issues like aortic aneurysms.
Right. Certification is annual, but the ME must disqualify the driver immediately if the abdominal aortic aneurysm diameter reaches 5.5 centimeters for men or over 5 centimeters for women.
Or if surgery is recommended by a vascular surgeon.
Correct. And even something as common as a DVT, deep vein thrombosis, needs strict adherence to the safety mandate. There's no specific waiting period number, but the driver shouldn't be certified until the cause is confirmed and the treatment is stable and adequate.
And a current DVT is automatically disqualifying.
Yes, due to the risk of a pulmonary embolism.
Okay, finally, that exercise tolerance test we keep mentioning, the ETT, it must meet stringent criteria, right? What defines an acceptable ETT result for the FMCSA?
It must exceed 6 meets. Practically, this means completing stage 2 or 6 minutes on the standard Bruce protocol.
And crucially,
the test must show no signs of ischemia. That means no characteristic angina symptoms and specifically no 1 millimeter ST depression or elevation. If they can't hit 6 meets without signs of ischemia, they cannot be certified, period.
okay, let's transition into the complexities of chronic conditions and medications. This feels like a minefield, starting with insulin-treated diabetes mellitus, or ITDM.
It is, and this has been a massive area of regulatory change recently.
A prime example of that friction between old rules and new reality.
It really is. Under current law, to be certified, the driver must present the MCSA 5870 form, which is completed by their treating clinician.
The person managing their insulin.
Right, and the paper trail is intense. The driver must have maintained at least the preceding 3 months of electronic blood glucose self-monitoring records.
No paper logs accepted.
No. But the MEA does have some discretion, which is often tested on the exam. If the driver doesn't have the full 3 months of electronic records, an ME may grant up to a 3-month certification interval.
To allow them time to comply with the monitoring requirements.
Exactly. Now, here is where our sources revealed that concerning conflict.
Okay.
Despite the new progressive rules, comments from certified PAs noted that some exam questions regarding diabetes, for instance, suggesting insulin use is always disqualifying, or that oral antidiabetics require a federal waiver, were woefully out of date.
This is critical for the learner. Even though the FMCSA has updated its guidance, the test bank might still reflect obsolete regulations.
The immediate disqualifier, which is current, is severe hypoglycemia. If the driver has had an episode 1 requiring assistance or resulting in loss of consciousness, seizure, or coma within the preceding 3 months, they are disqualified.
Until that safety window passes. Let's move to other complex neuro and mental health conditions where waiting periods are strictly enforced.
A transient ischemic attack, or TIA, requires a 1-year temporary disqualification.
And this is a decision based on the high risk of a future full stroke event happening while they're driving, right?
Precisely.
Epilepsy is even more tightly regulated.
As it should be, given the catastrophic risk of a seizure at the wheel. A driver may be certified if they have been seizure-free and medication-free for 10 years.
But
even with that 10-year clean record, they must have current follow-up with a neurologist to confirm control. Lack of documented follow-up, even after 10 years, can lead to disqualification.
And mental health issues. They also trigger specific waiting periods.
Yes. For example, a driver with a documented suicide attempt 10 months ago would be temporarily disqualified because they are within that mandatory 1-year waiting period.
And sometimes it's not just documented history. Suspicion warrants caution.
Absolutely. If a driver's distant, exhibits a flat affect, lacks eye contact, the ME should refer them to a mental health professional prior to certification consideration. The ME's role is to ensure psychological stability is confirmed.
Sleep apnea is the classic scenario on the exam, I bet. The driver who's tired, snores, is obese, but hasn't been tested.
A driver with suspected undiagnosed sleep apnea should be disqualified until formal testing rules it out.
And if they're controlled with a CPAP.
Then they need a compliance report showing regular usage. But mirroring that diabetes rule, an ME can grant a 3-month temporary certification if they don't have that full compliance report immediately available, provided there's a plan in place.
Finally, we need to cover medications that create immediate, non-negotiable disqualification.
First and foremost, using medical marijuana, even with a valid state prescription, is a federal disqualification for CMV drivers.
The federal government recognizes 0 exceptions there.
0. The same rule applies to antabuse, which is used to treat current substance abuse disorders.
Then you have medications that require a consult with a prescribing doctor.
Right. Opioid medications like hydrocodone or Avinza require the ME to contact the prescribing physician to obtain written clearance that the driver is safe to operate a CMV while on that prescription.
And in a classic exam scenario, the smoking cessation medication Chantix is noted as not recommended by FMCSA.
Which often leads to disqualification in practice scenarios, even though the clinical data on its safety has evolved. Again, we see that friction between the rulebook and modern clinical consensus.
So if you were to boil it all down,
The key takeaway for anyone studying for the NRCME is that the ME's job is less about the general art of medicine and more about adherence to these specific regulatory high-stakes thresholds.
you have to know the numbers.
You must know the numbers. LVEF must be greater than or equal to 40%. The ETT must exceed 6 meets. And you have to master the nuances between a 1-week waiting period for a PCI versus a 3-month waiting period for a CBG.
Right. And before you even get to those clinical requirements, you have to navigate the intense administrative complexity, completing the training, getting your DOT number, potentially dealing with backlogs using those calling hacks.
And committing to that 10-year testing and ongoing 5-year training cycle.
It's a career built on regulatory dedication.
It truly is.
And that intense reliance on the regulatory book rather than pure clinical judgment brings us back to our final thought. Our sources show that while the FMCSA actively updates guidance, like with the 2024 handbook, test questions sometimes lag behind, like those friction points we noted around modern diabetes treatment. This raises a fundamental and critical question for MEs in a field defined by public safety. When the regulatory rulebook used for certification conflicts with modern evidence-based medicine, should the ME certify based on their safest clinical decision or strictly adhere to the potentially outdated letter of the FMCSA regulation as represented by the exam? That 71% score hangs in the balance.